Everyone communicates in various techniques and differently with certain people as well. I would like to believe that I have learned and practiced communicating effectively with different groups of people, including friends, family, coworkers, patients, and their families. As a new graduate nurse, I know that I must engage in various forms of communication, pay close attention to the verbal and nonverbal cues I am using and my patients are using as well. The roles of sender and receiver are constantly interchanged between myself, my patients, my family members, and coworkers. It is unrepeatable but similar. I may communicate about the same disease process, but will adapt my method based on my patient's status, culture, and others. Appropriate and therapeutic communication are essential in building positive and beneficial relationships with patients and their families in all aspects of healthcare, but they are extremely important in nursing relationships, as we are the caregivers for the majority of their stay in the acute care setting. I must always try to be aware of the subjective and objective communication we hold together. For example, when I am trying to explain discharge instructions, which are usually very specific or subjective, I must be careful to keep my own personal beliefs on their care separate from the healthcare choices they make, but be detailed and objective in the signs and symptoms they should be aware of. Then I usually have them demonstrate or verbalize what they understand about the instructions, as well as give them a chance to ask questions to clarify the information they may not comprehend. We are constantly going back and forth as both the sender and receivers of information. During a hospital stay, it's equally important to be careful of the setting in which a diagnosis, care plan, or disease process is explained. The context. It is not a good idea to choose to talk with the patients as visitors are there, the TV is on, or when physical or occupational therapy is working with the patient. This applies to the noise and context variables of communication. The room needs to be free from family unless they are participating in the patient's care, or the patient is mentally incapacitated for one reason or another, which is often a barrier to communication, especially in stroke patients who often suffer serious consequences to the communication, such as aphasia, in which they cannot appropriately communicate what they're thinking. In this case, my communication may very well be with the family about the patient's care. And here again, the rules of sender and receiver, as well as subjective and objective, apply. Channels are also important, especially smell and sight. The reaction of a nurse to the many different smells in the hospital are important, as not to distress the patient or make them feel uncomfortable. You must hide on your face what your senses are telling you. Communication in healthcare always encompasses cultural, social, psychological, and temporal context when collaborating with the patient and the healthcare team. For example, culture. If a patient is a Jehovah's Witness, we must be knowledgeable and accepting about their choice to often refuse blood transfusions. During a major trauma, this conversation will also take place in the emergency department or the physical context, and the situation is then often stressful for the doctors, nurses, and family. Being aware of a set of culture beliefs is essential in my scope of practice, as it will guide communication as well as direct physical care. As a new nurse, one surprising factor I have found in myself that has been difficult is dealing with the negative feedback I receive from some patients. When I am trying to discuss tobacco cessation, I often get the nonverbal cues, such as eye rolls and frowns, and our sarcastic replies, such as, yeah, I know if I don't quit smoking, I could get cancer or die. This is when it is sometimes difficult for me to stay positive and not be defensive. I simply inform them of the risks and possible negative side effects and hope that just one person gets it. I am often harsh on myself. Next time, be more sensitive. Contrary to my personal feelings, the majority of feedback I've gotten from coworkers and my unit manager has been positive feedback. My director just last week at my 4-week review told me my communication with families and patients is excellent. She did also laugh and say that I need to improve on my communication with the doctors and be more affirmative when requesting orders. I was also advised not to allow my coworkers to see the stress or nonverbal cues I sometimes carry on my face when I'm having a difficult day, such as I did today. Dynamic interaction with my patients, and it is constantly changing, just as their condition usually is. I often have the same patients 2 or 3 days in a row. This allows me to continue to address their condition or disease, as well as goals and concerns. We are constantly going back and forth, reevaluating the situation and discussing what will happen next. I especially enjoy discharge teaching with my patients newly diagnosed with diabetes, as this allows me to see objectively what the patient understands about giving injections and choosing healthy food options. This is where these symmetrical and complementary interactions take place in my communication. We first show them the steps in drawing up insulin and picking an injection site. We then watch as they do a return demonstration. Next, I will give them a list of low sugar and high sugar foods and ask them to meal plan. In this situation or context, I can determine the likelihood of the patient adapting and being efficient in their own healthcare. Confirmation and rejection. I had a great example of these reactions today. I had a very rough day at work, and I was venting to a fellow coworker that I'd messed up all day and was not performing to the best of my abilities. My coworker rejected this notion of myself, stating, "It takes a while to feel confident. You're doing fine." This also encompasses the internal feedback I am constantly giving myself, as well as the external feedback from coworkers and patients. Every day, my techniques change, and each interaction with a new patient is a chance to learn and grow as a person and improve my communication skills. One day, I may have a difficult conversation about approaching death for a seriously ill patient and be more sensitive, while the next, I may need to be more aggressive when handling a patient with substance abuse. I am careful of my facial expressions and tone and using different styles every day. I pay attention to fellow coworkers and try to emulate their techniques to see if they work for me and still use my own as well. I hope one day to be able to assist a fellow nurse in doing the same.